Master DAPT trial assessed an abbreviated duration of dual antiplatelet therapy in patients at high risk for bleeding after implantation of a drug-eluting coronary stent. Randomization was done 1 month after implantation of biodegradable-polymer sirolimus-eluting coronary stent in those at high bleeding risk. Abbreviated therapy group discontinued dual antiplatelet therapy immediately and continued on single antiplatelet therapy. Standard therapy group continued dual antiplatelet therapy for at least 2 additional months. There were 3 ranked primary outcomes. One was net adverse clinical events, a composite of death from any cause, myocardial infarction, stroke, or major bleeding. Second was major adverse cardiac or cerebral events, a composite of death from any cause, myocardial infarction, or stroke. Third was major or clinically relevant non-major bleeding. Cumulative incidences were assessed at 335 days. First 2 ranked primary outcomes were evaluated for non-inferiority in the per protocol population. The third outcome was assessed for superiority in the intention to treat population. In the per protocol group of 4,434 patients, net adverse clinical events occurred in 165 patients in the abbreviated therapy group and in 172 patients in standard therapy group. Major adverse cardiac or cerebral event occurred in 133 patients in the abbreviated therapy group and in 132 patients of standard therapy group. Both these met the criteria for non-inferiority. There were 4,579 patients in the intention to treat population, 148 patients in the abbreviated therapy group and 211 patients in the standard therapy group had major or clinically relevant non-major bleeding. This met the criteria for superiority with P less than 0.001. So, the abbreviated therapy had lower bleeding with similar MACE and NACE compared to standard therapy. The median duration of DAPT was 34 days in the abbreviated group and 193 days in the standard therapy group in this clinical trial. Choice of P2Y12 inhibitor for DAPT and the type of monotherapy after the discontinuation of DAPT were at the discretion of the investigator. Clopidogrel was the most frequently used P2Y12 inhibitor in the standard therapy group and was the most frequently used monotherapy in the abbreviated therapy group at the time of randomization and thereafter. Master DAPT trial was an investigator-initiated open-label randomized trial. Patients with or without oral anticoagulant therapy after coronary stenting were included. There was stratification of randomization by concomitant indication for oral anticoagulation. NACE and MACE did not differ with abbreviated antiplatelet therapy in patients with high bleeding risk with or without indication for oral anticoagulation. Lower bleeding rates were noted in those without an indication for oral anticoagulation. It was driven mainly by a reduction in Bleeding Academic Research Consortium 2 bleedings. In this context, an earlier meta-analysis had shown that double antithrombotic therapy, particularly if consisting of a non-vitamin K oral anticoagulant instead of vitamin K antagonist and P2Y12 inhibitor, is associated with a reduction in bleeding. This included major and intracranial hemorrhages. The benefit was counterbalanced by a higher risk of cardiac, mainly stent-related but not cerebrovascular ischemic events. That analysis included 10,234 patients in 4 trials, in which 5,496 were on dual antithrombotic therapy, while 4,738 were on triple antithrombotic therapy. 2020 European Society of Cardiology European Association for Cardiothoracic Surgery guidelines for atrial fibrillation recommends abbreviated periods of triple antithrombotic therapy in those with coronary stents. When the risk of stent thrombosis is low and risk of bleeding deemed high, they suggest stopping aspirin within a week and continuing NOAC with P2Y12 inhibitor, clopidogrel preferred, for up to 12 months in patients undergoing uncomplicated percutaneous coronary intervention in acute coronary syndrome. Triple therapy up to 1 month may be considered if the thrombotic risk outweighs the bleeding risk. The corresponding duration of dual antithrombotic therapy with NOAC and clopidogrel in PCI for chronic coronary syndrome is 6 months. Aspirin is stopped within 1 week if the bleeding risk is more than the thrombotic risk. Just as in case of ACS, when the risk of stent thrombosis is deemed higher than the bleeding risk, triple antithrombotic therapy may be considered for up to 1 month. It may be noted that the duration of DAPT recommended in the 2020 ECS EACTS guidelines for those at high bleeding risk and AF was lower than the time of randomization in master DAPT trial, less than 1 week versus 1 month. But ultra short period of DAPT may be associated with higher stent-related ischemic events. First set of journal references. Second set of journal references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video. Kindly press the bell icon after that for getting all updates.